To me, the important messages are you need to get cervical cancer screening. Okay. We can start at 21.
Yeah.
And if someone's HPV vaccinated, I feel a lot more comfortable by saying, okay, you can wait till 25. I see that's kind of up to you. And I equally have women who are going like, great, I don't need one. I don't want the test. And I have another one who says, no, my mom really wants me to get a pap smear. Fine, we'll do a pap smear.
Today, we're diving into the world of HPV with Barbara Moscicki, an incredible researcher from UCLA who has been working in this space for a very long time. We explore the 5% of cancers that HPV causes. It's all cancers. We talk about the shifting in guidelines for cervical cancer screening, HPV vaccinations, and what both patients, parents, and clinicians need to know to get screened at the right times. What really stood out to me was that we need to give providers ammunition to help the patient decide what's right for them and the type of screening that is appropriate for them given their life context and their age. Take a listen, and I hope you take away something that helps you. I have a very cool guest with me today. I have Dr. Moscicki. Sorry, did I get that right? You may have
Close enough.
Close enough. We will get there. On our episode to talk about something that I think is really important to the women's health space. So with that, Dr. Moscicki, can you please tell us a little bit about you, your background, research, etc.?
Certainly. I'm a pediatrician, and I specialize in adolescent and young adult medicine. And so I took a relatively long road to research, even though my father was a general practitioner, and I thought that's what I would always be. After my pediatric residency, I did a fellowship in adolescent medicine, and I fell in love with research. And I loved asking a question and trying to answer it, but it usually was like Pandora's box. It just kept having more and more questions. But that actually made the field really fun. I went on to do another fellowship in STD epidemiology, and then I did one more fellowship in molecular virology. So I kind of like found my niche by doing many fellowships and really finding that, during, I think, my last fellowship, I really got attracted to human papillomavirus, the cause of cervical cancer. And I really said, this is like, do we really know it's there? Do we not know it's there? But obviously it's such an important question because cervical cancer is an important cause of both mortality and morbidity worldwide.
Before we get too deep, can you tell us where your last name comes from?
It's Polish.
Ah.
Actually, one of the last presidents of Poland when World War II broke out was President Moscicki.
Did not know that. Okay. So I actually started my career in virology. I was working in the lab, and I was always fascinated by infectious diseases. And in the last job, when I got diagnosed with breast cancer, we were working on a rapid PCR device for STD testing. So all this to say that I might be nerding out today, just a heads up. So I appreciate you bearing with me. So with that background, can you tell us a bit about what we know today about HPV viruses causing cervical cancer? Is that the only cancer it causes? In the world of like infectious diseases, virology meets oncology, just a super high level overview would be a great place to start.
So when I started out, they even questioned whether it was the cause of cervical cancer. And that's all we thought, and that's kind of where we landed. And in that meantime, this field has absolutely exponentially blossomed, I'm going to say, because we now know it's the cause of at least 50% of vaginal, vulvar, and penile cancers, probably more than 70% in penile cancers. And it's also about 85% of oral pharyngeal cancers. And predominantly, we're seeing this enormous increase of HPV-associated oral pharyngeal cancers, particularly in men. It's almost like an epidemic. And as of last year, there were more cases of oral pharyngeal cancers in the US than there were cervical cancer. And the other most important one is anal cancer. It's also probably 90% of anal cancers are HPV associated as well. So this is a virus that really targets both mucosal and squamous cell, tissue. And I think we haven't finished the story yet. We are finding more and more potential association with cancers, including what I described to you are what we call alpha HPV types. But these are all kind of like, the genetic categorization for HPV, based on its DNA sequencing. But we also are looking more into what we call beta HPV. We think that we're kind of commensal, they're part of our body, but in the wrong circumstances, they may be able to cause skin cancers as well. So the story continues to unfold. But HPV, even though you can find it in a lot of places and a lot of our body parts, is, probably commensal under some situations and is a pathogen under different situations. Sorry.
Okay, a series of dumb questions. I have a
As they say, there is no such thing as a dumb question unless it's something I just covered and you're asking me it all over again.
Oh,
Even then it's not. No, that's called clarification, right?
I haven't heard that one before. Okay. So there was something you said about being commensal and pathogenic. And my question is, when we think about STDs, more traditional, like chlamydia, gonorrhea, trach, things of that nature, there's this
non-commensal.
There's this moment of acquisition, right, where I acquire it because I had unprotected sex or something like that. What is the story with HPV? Because it sounds like it could be both-ish.
Both-ish, yes. So currently, I think we're up to categorizing over 250 different HPV types. And we kind of worry mostly for what we call the 14 oncogenic types, but we keep on kind of downgrading even what we call high-risk types to now probably 12 of the most high-risk types. And those other types can be found, like 80% of women who've had sex will acquire HPV over time. 90% of those will clear, even if it's an oncogenic type. So the question always comes, what is it? Why persistence happens and we don't find persistence? And that's kind of a story into itself, because a lot of people question persistence versus, is this kind of a latency? Is it viral control versus is it true clearance? Said that, we'll say you can't find the HPV any longer, so it's either cleared or it's under viral control, immune control. And, when we find lots of little HPV, when you find it and you don't find disease, we kind of say that must be commensal because it can live with us and not cause harm, which is probably very important. And when you look almost at any site, at one point you're likely to find it. And we find it in one person, and there's been studies of partners. You don't necessarily find it in the partner. So again, making all of this kind of transition dynamics kind of hard to pinpoint. We know it's easily transmitted sexually, but we also know a lot of people have really good immune control and they don't end up with disease. On the other hand, we know viral persistence, that is persistence detection, is a risk factor for getting cervical invasive cancer. So in that sense, under bad circumstances, HPV acts bad. You think about a virus, they need the host cell machinery to survive. So they don't want to kill their host. This is like the wrong thing to do. And so we always say maybe it's HPV did a mistake and at times can kill its host because somehow it takes over the host cell machinery and kind of overdoes it. Suddenly the virus starts expressing what we call our viral oncogenes, and those kind of basically kidnap the system, and it turns off apoptosis. It turns off all that cellular regulation, but it's not all the viruses. It's the ones that end up causing cervical cancer. In that is probably, the ultimate how these oncogenes work. But the final steps into invasive cancer still are murky, to say the least. We kind of blame E6 for helping the degradation of P53, an anti-oncogene, and E7 for interacting with the retinoblastoma, gene, and again, stopping cellular regulation. But you start looking at all the in vitro regulations, there are a list of like 100 different cell signals that E6 can interact with. So we always say, there's more than one road that leads to Rome. We know that there is more than one road that leads to cancer. So it's probably genetic errors in many ways.
Can you tell us how the E6 virus that has sort of taken over the host cell mechanism, oncogenes start showing up? We're not super sure about how that causes cancer all the way through the pathway. But then we have the advent of screening and pap smears. And how does the world of screening and pap smears start to intersect with the 14 or 12 different types of HPV that we really care about from a cancer perspective?
Okay. So I'm going to back up a little bit to talk about, against E6 and E7. Those are proteins expressed by HPV, and those are what we refer to as our oncoproteins. And so both of them cause a cell deregulation. So when a cell goes bad, there should be apoptosis. It stops that. When cells are mitotic, you don't want them to continue replicating, but they will continue replicating because of the interference from E6 and E7. So all of those end up making cellular changes. And those are picked up by what we refer to as the pap smear. That is, all of a sudden you pick up these mitotic figures. You pick up these cells that shouldn't be, they should only be in the basal cell layer. But now there's some that go all the way up to the very top. And those, when you have abnormal proliferation from bottom to top, we call it cervical intraepithelial neoplasia 3. We used to call that carcinoma in situ. And basically, it tells you that that is a true precancer. And if you don't treat it, there is a 15% chance, over 15 years that will become a cancer. So, that is what a pap smear is all about, are picking up precancer changes. So that's kind of like the intersection, and that was first described, right, by Pathogenic many, many years ago, that when you take a little swab, you may be lucky and you get some of those abnormal cells that will be on a slide. We've moved the field to now what we call liquid cytology. And so we now do the same little scraping, but we put it in a little vial of basically transport specimen media, but it also kind of like fixes the cells so they don't denigrate. And then we have a machine that kind of spins those cells down onto a monolayer on the glass slide, and then you do the staining. Because if you remember the good old pap smear, it literally was a schmear. And so it was a pathologist like looking under like different layers, going up and down, trying to figure out if they could find the cell. But now in a single monolayer, it's so much easier to read the cell and say, yes, I think this is abnormal, this is not normal. So cervical cancer screening, and that is the intersection of picking it up using liquid cytology. But we also know there's a few nuances to that, and that We can also pick up what we call low-grade disease, and I'll refer to that as CIN1. We used to call that, a low-grade dysplasia. And that CIN1 is not what we call a precancer. We know that that's just picking up viral replication, and that's likely to go away. So you've got also a 90% chance that that CIN will go away. Then we have something in between. It's called a CIN2. And depending on who you talk to, this is an intermediate stage on your way to a CIN3. On the other hand, if you put 50 pathologists into a room, 50% of the time they'll agree on what's a CIN2 and 50% of the time they'll disagree. So if we consider CIN3 the absolute precancer. No questions about it, you need to treat it. CIN1, you don't need to treat. CIN2, this is where the dilemma comes. As I told you, not everybody agrees. So what if you missed a CIN3? And that's really what it was, because another pathologist called that. So we tend to treat women with a CIN2 and above, and a CIN1 we don't. But again, there's many nuances to that, because if you're young and you don't want treatment right away, that CIN2 still might go away. So you can choose to have it followed. Actually, you can always choose to have it followed. But in young women who say, I want to have more children, I want to have a child, there's a slight increased risk that you'll have premature labor, associated with having what in the US we call it a LEAP, or an excisional therapy. And so with that, we kind of give women the opportunity to make a decision around the CIN2.
Really dumb question. Sorry. Pap smear is only for cervical cancer screening, right? But at the beginning of the conversation, we talked about how vaginal, vulvar. So how do those two things? Yeah.
Right. So, and I'm going to use the term pap smear, but again, remembering we use liquid cytology now. And even though the staining are still the same, that we have now started using the same thing for anal cancer screening. But we have identified very high-risk patients, sorry. And those are those living with HIV or immunosuppressed, like solid organ transplants, or women who already have other, like cervical cancer, vulvar cancer. We recommend that you have this. It's basically an anal pap smear. But said that, and we categorize it virtually the same. Again, an AN1, 2, and 3. And we ask you to come in low grade, high grade, and then that refers you to basically what we refer to as anoscopy, but it's using the same colposcope, but looking in the anal canal itself. We have no screening for vulvar cancer, vaginal cancer, or oral pharyngeal cancer. Basically, at that point, you're almost picking up cancers, which is unfortunate, but that's why dentists will sometimes, check your lymph nodes. They'll actually even take their finger and check your tonsillar area, because the oral pharyngeal cancers are basically the base of the tongue, which you can't really feel, or the tonsillar area, but they often present with a large lymph node, which is why it's important to look in the neck lymph nodes. But unfortunately, those are, you pick up cancer. One thing to say about the anal cytology screening is you have to have someone who knows what to do in the next step. That is, how to do that anoscopy that I just talked about. We don't have enough individuals who are skilled in anoscopy. So you don't want to do a test and have nowhere to send the person. So there has to be, a chain of command, as they say, when you're going to decide to screen with someone. And I think we know that in the US, boy, there was a long time before we got the whole train going. You screen, how do you screen? And then where do you get them to? Who's trained? The biopsies, treatment. It takes a while, and it's always evolving.
Can you talk a bit about guidelines in terms of USPTO guidelines for cervical cancer and anal cancer?
Okay. So as usual, not all individuals who make guidelines agree with each other. So currently, as you all know, I talked about pap smear screening, and that was there like forever. And many years ago, we went into something called co-testing. That is, if you do a pap smear alone, you're going to miss disease, sometimes up to 50%. The only reason it worked in the United States is that we did it repeatedly. So if you missed it, you came back, you did it again and again and again. But if you just count on one, it's a 50% toss up whether you're going to pick up what you're looking for. And the other problem is it's really hard to pick up those high grade cells. So we know that a lot of times a low grade is sitting right next to a high grade. So unfortunately, we refer women with liquid cytology who have low grade stuff. Why? Because they actually have a high grade. It is not until you go in there and you look with the colposcope and you take a biopsy that you go, that was a high grade. But you still have lots of over referrals. But it's again to pick up what we're looking for. A lot of women need to be over referred. Then we kind of moved many years ago into what we call HPV co-testing. So a lot of people were like, well, why are you looking for the disease if they don't have HPV? Because I just took 95% of cervical cancers are due to HPV. So it's kind of like looking for hepatitis and they don't even have hepatitis, So we kind of like added the co-testing because the initial one said, oh boy, I could make this test way better. So it turned out that if you have a negative HPV test and you have a negative or normal cytology, chances are you don't have cancer. You don't even have a precancer. So that negative predictive value allowed us to increase the intervals to every 5 years. So we moved away from every year because studies showed us if you do it every year, you're going to pick up a lot of schmutz and you're going to increase the over referral. So we went to every 3 years. And then the studies came out, actually out of Europe first, that really showed us when you do co-testing and if they're not there, then they're good for 5 years. So we were able to extend that interval. The nuances come. We said, okay, but there's a lot of HPV in young women. I mean, a lot. It's like 20% in young women, under the age of 25, and it drops dramatically down to 10% when you start getting over the age of 30, 35. So we all kind of said, HPV, boy, then you're really going to start just having all these young women come in for colposcopy, for treatment, and you start this, and they're going to get rid of it. They're still young. They have time. And so we kind of said, let's start at the age of 30. That is when we'll do co-testing. Because that's when if you miss it by cytology and you're HPV positive and you have a bad type, the 16 and 18, that's the bad actors. 16, 18, 45, that's 67% of all cervical cancers. So those women now will go straight to colposcopy. If you have some other types and you have a normal cytology, they're not going to tell you, I'll just see you later. It's, I'll see you in a year. And then if any of those tests are positive at the end of a year, then you go into colposcopy. If you cleared it, you're normal, you're good to go. And then if you're under 30, we ask you to continue doing cytology at every 3-year intervals. And we used to start like the day you had sex. It's like, come on here, come in and get a pap smear. When we changed it, we said, well, that's an overkill. And then we kind of moved it up to say within 3 years. And then we moved it to say 21, because you really just don't see cervical cancers under the age of 24. So, I mean, you do, but they're rare. And so we kind of move that needle to where the U.S. Preventive Task Force is. We start with cytology, 21, co-testing at 30, but the American Cancer Society came in and threw a little wrench into that one. And they said, let's just start with the cause of cervical cancer. It's called primary HPV screening. Now, the U.S. task force says you can do that too, but starting at the age of 30. What changes is that American Cancer Society said, forget that cytology. Why don't you just start at the age of 25 for everybody? Why? Because more and more women are getting vaccinated. We know that that's not a fair distribution throughout the U.S. Many states, particularly in the South, have very low rates compared to other states that have very high rates, over 75%. And we know we got herd immunity, we're vaccinating both boys and girls, and even if you're not vaccinated, you're protected because of herd immunity. So now we're sitting around with these two kind of recommendations, and the U.S. Preventive Task Force kind of asked for public opinion, and I believe that's still out for public opinion until the final stamp will be done. But it's, a lot of it's betting that we have a lot of people vaccinated, and I'm sorry to say, but I think our vaccination rates are likely to go down over the next decade rather than continue going up. So we're going to, which is just makes me incredibly sad because Australia has seen and Sweden have seen their cervical cancer rates plummet already in the age group we would expect. And of course, there's other diseases that are plummeting as well. One is called recurrent laryngeal papillomatosis. It's not a common disease, but it's passing of HPV 6 and 11, which is associated with genital warts, into the larynx of infants. And you can imagine if a wart grows in a teeny tiny larynx, it can obstruct it. So they often get surgery after surgery after surgery, these lasers, and these just come back. Well, again, we've shown with good coverage, young women are not transmitting this to their child. And we've seen the rates of this, RRP, go way down. So once again, there's so many lives that we can save by getting HPV vaccination in there, not to even say the oral pharyngeal cancers in men and in women themselves. So go back to the cervical cancer screening. It's not an easy message. And I think, providers have to have a tool. They have to feel comfortable. And they have to know when their patient says, but doctor, I just read that I can wait till I'm 25. Why are you asking me? I'm 22. I need, a pap smear. So these are really important things. And I think providers have got to give themselves ammunition to be able to adequately address patients' concerns. Because when our guidelines do not necessarily line up, that causes confusion for providers and for patients. And we know cervical cancer screening saves lives. There's no question or ifs about it. It has to be done in a very cost-effective way. We cannot overburden patients. We cannot, overtreat them. So we have some outs. So let's just say a 21-year-old gets referred to colposcopy. If she has CIN1, you follow her. If she has CIN2, you follow her. You don't have to initiate treatment. So, there are we have some backups. And I would say there's another problem we ran into. Not all laboratories are set up for primary HPV screening. So I will use my institution as an example. They couldn't figure out how to do billing. So guess what? We couldn't offer it. It gets complicated when we have a recommendation, but it can't really be instituted by everyone. So I want to go back a little bit about what primary HPV screening is. It means you're going to get tested first for HPV. If it's abnormal, it's positive, you have a high-risk type, 16 and 18, you go off to colpo. They'll still read your cytology. So we collect them in the clinic by a provider who puts it still in the same little vial, but it's a backup now. If you're negative, I'm not going to run anymore. Isn't that a cost savings? I don't have to do, the cytology on a negative HPV. If it's positive, you have a couple of options. One is you do cytology. And another option, which again is not available at a lot of clinics, is called dual staining. It actually stains the cell for those abnormal proliferation markers. We call it dual staining. It stains for P16, Chi67. Again, these are kind of, if you want to say it, bystander outcomes of abnormal cellular proliferation. So the key here is primary HPV screening. If you do both tests, then I don't have to ask the woman to come back in. We are now moving to self-sampling. So a woman now can go into the clinic and say, gosh, I don't have time for a pelvic and a pap smear today, doc. And the doc can say, great. When you get your chlamydia and your gonorrhea, here's a swab and you do one for the HPV and we'll do primary HPV screening. So currently it's approved in the FDA for in the clinic. That is, it comes with a little bit of that transport media, and God forbid a woman would drink it at home, so they don't want anybody having it home. And so we put it in, then we send it off to the lab. Well, if that is positive, that woman has to make another trip back, right? She's positive. Now I need to do a triage test to figure out what I should do with you next. So it's a trade-off. Are we going to reach more women because they can do self-sampling? Or can we, and again, to me, that's a patient decision. If you have the option to offer both. Within the last 2 weeks, the FDA approved a self-sampling tool that you can do at home. And so I think I'm going to tell you, it surprised the HPV community. Yeah. All the researchers, caretakers, no one kind of knew this was even on the radar. I mean, companies have been wanting to do this. It's not a question. But the self-sampling allows them to mail the sample dry.
Oh, wow.
Now, not covered by insurance. You still have to pay out of pocket for it. They'll do the HPV testing for you. So I'm sure someone who knows STD testing, you can get a home chlamydia test. You can get a home gonorrhea test. You just pay out of pocket, and you hope they're doing a CLIA approved assay, and you hope for the best. So that is how complicated things have gotten over the past year.
Oh my God.
Where to go next, right?
I know. I was like, you just. So
to me, the important messages are you need to get cervical cancer screening. Okay. We can start at 21.
Yeah.
And if someone's HPV vaccinated, I feel a lot more comfortable by saying, okay, you can wait till 25. I see that's kind of up to you. And I equally have women who are going like, great, I don't need one. I don't want the test. And I have another one who says, no, my mom really wants me to get a pap smear. Fine, we'll do a pap smear. Now, that 21 is not for women who are immunocompromised. So the solid organ transplant, the patients with lupus, those are still supposed to start at 21 years. And we still recommend that they do cytology only, because those women who are immunocompromised are even more likely to have HPV, like 50%. So what do I do with that information? It really starts a terrible loop. So the message is, okay, we need to do it. But if I don't do it today, remember when you're 25 that you're supposed to get that. And so, you are putting a little bit more burden on the woman, which is again an important thing to remember. And again, I think as long as people are getting patient care, but we all know insurance, it comes and it goes. There's so many questions that fall into that. And so, I think the message are, have you been HPV vaccinated? You haven't. You should be. And has your child been HPV vaccinated? If not, I would recommend that.
Okay.
And then, my message is your boyfriend HPV vaccinated? I don't know. I'll go home and ask him. I said, that's a good question. So I think we can give prevention, and that's HPV vaccination, and we can give prevention. You need cervical cancer screening. And there are some choices. Isn't that great? I'm going to give you a choice. And I can give you my opinion, but it's still a choice.
Doc, I'm watching the clock. This has been honestly
Yes.
one of the most fun conversations I've had, because I haven't spoken about the intersection of virology and oncology ever on this show, so I appreciate it. I love the messages to the community at large. My question for you is, if you could tell, as a wrap up, leave clinicians with a key message, who would you want to talk to and leave a message with? And what would that message be?
Well, same messages. You need to promote HPV vaccination. It's a health one. It should be for males and females. You should know that you're preventing not just cervical cancer, but anal cancer, oropharyngeal cancers, vulva or vaginal cancers later on, penile cancers. Again, these are rare, but they make up all the cancers. 5% of all cancers in the world are due to HPV. If you think about that, that kind of blows your mind away.
Correct.
And so I think, and it's a preventable cancer, right? So we need to understand, they need to feel comfortable about HPV and the myth out there. It does not cause autism. They've done good, comparisons, with the registries and whatnot. There's no evidence associated with Guillain-Barré. There is no association with, muscular dystrophy or multiple sclerosis. We're not finding those when we look actually, in any kind of signals, right? They look at the registry of complaints and then you look at the background. So it's a safe vaccine. Again, the messaging around number of vaccines. The good news is if you're under 15, you only need 2, which is how I sell it to all my younger adolescents. Say, hey, you're 14. Next year, you're going to need 3. And they always look at their mother and say, okay, I'll do it. So, really understanding, how important the HPV vaccine, and understanding that there are myths. And so number one reason that mothers will say why they didn't have the HPV vaccine is because they said their provider did not recommend it. So we have to be out there giving them messages that, measles and mumps and rubella are important, but so are HPV vaccines. And we've now moved it down to 9 to 11-year-olds. And we're kind of moving the needle along the way with more and more studies. The second thing clinicians need to feel comfortable with is understanding that there's more than one guideline. And they can just kind of say, this is my practice, and this is how we're going to practice here. But they need to be prepared to, when the woman asks the question, like, I'm going to start at 25 because all my patients are HPV vaccinated. And then the mom says, I brought her in to get a pap smear and she didn't get one. And you kind of say, well, American Cancer Society says I can really wait till she's 25. And when I spoke to her, she's 21. She gets to make her own decision. She chose to say it's okay. But then it was questionable. No one said I could get one at 21. So I think that's the careful messaging, that you need to know that there are different guidelines. And you can say, I follow the American Cancer Society guidelines, and they recommend we start primary HPV screening at the age of 25. And if someone says, yeah, but what about the 21? I said, well, you can still do 21 under these guidelines, but I tend to follow the American Cancer Society guidelines. So I think, again, it's just kind of making your practice feel comfortable for you. You can't go wrong, right? Neither one of these are wrong. The only time it's wrong is if we don't do it.
Yes.
And if we don't follow, we still do annual cytology. That's too much. If I do an HPV testing on a 21-year-old, that's dumb. We can't abuse the guidelines, but not doing the guidelines and not offering the woman. And if she doesn't want to be screened and she's past due, you need to ask why. And then saying, well, I really am so afraid of getting a pelvic exam. And saying, well, we could do this HPV test. You can do it right here in the clinic. It's a swab into your vagina. But if you're positive, I will need you to come back. But if it's negative, you're good to go for 5 years. So I think, again, in this field, which is, I would say, it's clear to me, but I know these guidelines. There's no way it can be clear to all the providers out there. And so it's really kind of understanding the two different guidelines right now. And then you do screening. There is something called the ASCCP app. It is an app you download, and it really helps to okay, I got a positive HPV test and a normal cytology. What do I do next? And it helps carry you through it. It's also free. You can get it online, but accessing a computer can sometimes be more of a hassle. But I know that there are institutions on Epic who have it on their in their electric medical records or their access. So there are helpful ways because the algorithms are very complicated.
That was phenomenal. I so appreciate you taking the time. I know it's been a busy clinic day for you. And I really, really do appreciate you taking the time because I know a lot of patients and quite a few providers, and I've never had such a succinct overview of what's happened in the space, the evolution, and where we stand today with the guidelines and what we're facing in the next 2, 5, 10 years in terms of even more dynamic shifts given new tests coming to market, new sampling methodologies coming to market, and what we might be seeing if herd immunity is achieved or not achieved as well. So
yes. No, and believe me, the testing algorithms are continuing to explode. Methylation assays are already commercially available in Europe, and they're not here. And it's just such an evolving field. And then people are looking for therapeutics, which, I'm HPV persistent. What do? I keep on having to go back to see my doctor. And so people are coming up with hopefully therapies that will also help women, rid themselves of persistent or even choosing a non-surgical treatment for precancers.
Thank you so much. I really appreciate it. I hope you
Certainly
have a whole long weekend. And
on call, unfortunately. So I want it to go fast.
All right, a very quick weekend with no problem on call.
All right. Well, it's very nice meeting you virtually, and wish you the best. And thanks for reaching out to people because this is really important and I think terribly confusing what we've done. I feel bad.
Confusing. And I'm hoping that at least this gives people some clarity. So thank you for doing that with us.
All right. Okay. Bye.
This podcast, show notes, and newsletter is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice, and no doctor-patient relationship is formed. The use of information on this podcast or any materials linked from this blog is at the user's own risk. The opinions of the speakers are their own and do not represent the opinions of organizations they're affiliated with, nor do they reflect the opinions of Mantacares Inc. or Mantacares' sponsors. This episode was supported by an award from the Patient-Centered Outcomes Research Institute.